Thank you so much. Hello, Dr. Chandrasekaran. Thank you so much for offering this incredible opportunity for our Club Med Virtual members. My name is Mariana. I am the event spokesperson for Club Med Virtual. I will be leading today's session, reading any comments posted in the chat, and facilitating the conversation as we go along. Before we start, I want to remind everyone to maintain proper etiquette and please stay on mute unless Dr. C specifies otherwise. If you have any questions, please post them in the chat and we will address them as we proceed through the session. A Google survey will be administered for Wayne State University students at the very end of the session to verify your attendance. It will close 30 minutes after the session terminates. And also please stay on the call for at least 5 minutes after the session closes or after the session is over to ensure that the survey is working for you. The session will also be posted on YouTube in case you are unable to attend or want to revisit certain topics that Dr. C discusses today. But you cannot receive shadow or attendance hours if you are not present in this call today and complete the survey. All right, Dr. C, I will turn the session over for you. I made you co-host, so if you have a screen you want to share, you can do so.
Yeah. All right. So before I start with our case, I just want to introduce myself. Thanks to everyone for being here. My name is Neena, Dr. Chandrasekaran. Mariano is so eloquent in pronouncing it, but usually I just tell my patients when I walk in, I'm like, "Hi, I'm Dr. C. Nice to meet you." But yeah, so I usually introduce myself as Dr. C. Uh, I might change it because now that I'm married now, but we'll see. I'm pulmonary critical care. I'm in my second year of fellowship, so one more year, and I'll be officially finally practicing. Just feels like it's been forever. So I started, I started 2011, I think. So I did undergrad in Nova, which is in Florida. I'm from Florida. Anyone from Fort Lauderdale, yay. But so I did my undergrad down there, and then I did my medical school in the Caribbean to American University of Antigua. So I was able to attend there for my basic sciences for 2 years. And then my clinical rotations were all set for the year. So I did my third year in Miami and then my fourth year between New York and Florida. And then I did my internal medicine residency and University of Pittsburgh Medical Center, so UPMC. And I'm board certified internal medicine because I finished that back in 2019. Yeah, 2019. And the years all just like, it's crazy. So yeah, 2019. And then I started my fellowship in 2019 itself. So I personally didn't take any breaks going through. I kind of just did it. So here I am. It's been quite a journey, quite a road. I'll talk about it as we go on. So what do I do? What's pulmonary critical care? Pulmonary critical care, pulmonary is the study of lungs. So I study, like they say, you're a specialist. So I'm a specialist in the lungs. Anything to do with any lung type of pathology, whether it's fluid in the lungs or COPD, which is like chronic obstructive pulmonary disorders, COVID. Apparently, I'm a specialist in that now too. Asthma, interstitial lung disease, pulmonary fibrosis. It's vast. Anything to do with the lungs is part of pulmonary. And then critical care is the ICU component. So we manage all the patients in the medical intensive care unit, sometimes surgical or neuro ICU as well. Being in the ICU, you're pretty much on death's bed, to put it, I guess, in more sense. It's you're really sick. If you're That's the sickest part of like the hospital per se. So you're either like on a ventilator, you're on medications to keep you to have a blood pressure. There's something that has to put you in there that is life threatening. So I love what I do. I love this field. I specifically chose this field because I like the aspect of both outpatient, inpatient, and the ICU. So just I like to have a connection with people. So I always admire the outpatient setting part of this. But I also like the fast paced part. I like to just think on my toes. Like if I had a patient, if I was walking into the hospital right now and a code blue is called, like patient doesn't have a pulse, then I'm the one who like will manage that. I mean, sometimes since I am a girl and I look like this, when I go into a room, everyone looks at me and they're like, but I'm like, now I'm the doctor and I'll start barking out orders and everyone will just, fall in line. But hey, women in medicine. Yeah, so I think it's cool. You get to think on your toes. You're always like up there. You're always kind of in charge and you're thinking. And I think that's just so cool. Everything moves fast paced in the ICU. It's not like a sitting and waiting game. It's now or it's do or die pretty much. So I think that's pretty cool. So I like that part, but I also do enjoy, like I was saying, the outpatient aspect. I think that's pretty cool that you do get to form a bond with these patients as outpatient. And then inpatient setting, I see patients on pulmonary consults, which is actually what I'm on now. So I'm on a mix of pulmonary inpatient consults and outpatient. So like from today at 7 a.m. to 12 p.m., I saw inpatient consults, and then at 1 p.m. I went to clinic, and then I was there until like 4:30. Yeah, so if you guys have any specific questions about pulmonary critical care, definitely feel free to drop them or just kind of ask me as we do go along. But I'm going to start talking a little bit about a couple cases to kind of illustrate a little bit more of specifically what I do. I hope I'm sharing the screen right.
Yeah, I can see your screen.
Just need to get to. How do you go to presentation mode? Doesn't make sense. Okay, perfect. So PCCM, that's pulmonary critical care medicine. It's kind of two different specialties, but it's also kind of one. Actually, it's two different specialties because you take two different board exams for them. It's just kind of put in together. You can do the pathway of critical care medicine from a few different things. I did it from internal medicine, but you can do it from emergency medicine, so like ER, or you can do it from anesthesia, or you can do it from surgery. So they can also go into ICU. All right, so we're going to start with a couple cases. This is something that I see every day, and if I ask a question and you guys know the answer, definitely feel free to drop it in the chat. If one of you guys can just let me know what people say. Okay, so case one. 28-year-old mild asthmatic or 28-year-old mild asthma in the past comes in for shortness of breath. One of the most common chief complaints or complaints that we get in the clinic is shortness of breath. And this is such a broad complaint. It could be almost anything. So then we try to elicit a little bit more information. So the patient says, he noticed when deep sleep, he would feel some slight difficulty taking in and out of a deep breath. When people describe shortness of breath, it's probably one of the worst feelings in the world, not being able to breathe. Hopefully none of you have gone through that / will go through it. But when somebody does come in with this, we kind of try to elicit a little bit more like, okay, so when, how, why, how exactly does it feel? Does it come on when you're resting? Does it come on with exertion? Does it come on all the time? Does anything bring it on? There's certain types of questions that you always try to ask with a chief complaint. And one being so broad, such as shortness of breath, we will go further to see what else this patient has. So being 28, I mean, a couple other things that we do always ask is past medical history. And this patient says as above, so just mild asthma. Past surgical history, he says just appendectomy. Past family history, that's always important to ask. He's saying mother with pancreatic cancer, father with some type of lung disease, and brother with asthma. Social history is always important these days. And with social history, another thing that we have been asking is specifically vaping. So I'll say, do you smoke anything? And if they say no, then I'll say, okay, do you vape anything? So it's kind of interesting. That did change back in like 2017 when like vaping associated lung disorder became a thing. So that's part of social history. And then in addition, is there anything else that you guys would like to know? So let's say you guys are the doctor and this is a patient coming in, a 28-year-old, so relatively young. He's coming in for shortness of breath. Notices it in deep sleep. He would feel some slight difficulty taking in and out of deep breath. And he's saying in sleep. And this is his, whatever he said here, past medical, surgical, family, social. So if you were the doctor, is there anything else that you would like to know?
Lena posted in the chat their weight.
Their weight? That's a great question. So weight does have a significant role in shortness of breath. Obese patients who do have a lot more muscle mass on them, they do feel like it is harder to breathe because that has been associated with certain types of respiratory illnesses such as obstructive sleep apnea and restrictive lung disease. Just because of the weight, they're not able to breathe in as much.
Miriam asked, do any habits change this?
Any habit changes? That's also a very good question, especially in somebody with asthma, because people have different types of triggers when it comes to asthma. For example, if somebody just started going around or started dating somebody that's wearing a certain type of perfume, different types of habits, like someone just got a new dog, a pet, maybe they're allergic. Someone just moved somewhere else, maybe there's mold or fungus in the new apartment. So that's a new travel anywhere. That's actually a really good question.
Sophia asked their activity level and exercise habits.
Those are great questions too. So yeah, that kind of goes along with obesity. Any activity, are they deconditioned? That's always on the table. Activity habits for sure. So just for the sake of time, I'll go through a couple other things that I would ask, and you guys ask great questions too. So for pulmonary standpoint, we go more further in. Like if this is what the patient told me, I'll say, okay, social history. Do you work? This has a huge implication in terms of lung diseases. Because if somebody told me that they work as a mechanic with cars, then I'm thinking, okay, maybe like they're exposed to some type of chemical exposures are big, especially here in the Northeast. I'm not sure how many of you guys are from the Northeast, probably a bunch of you from Wayne State and a few others, I'm sure. So back in the day, there used to be like a lot of cave workers. There used to be a lot of people exposed to different chemicals like berylliosis, silicosis, and this kind of leads to new lung diseases like we're learning, like asbestosis. Even silicosis can then lead to TB, tuberculosis. So that's definitely something important to ask. What do they do for work? And are they exposed to any chemicals? Other parts of social history that is really important to ask is pets. Always ask about pets with shortness of breath because maybe they are allergic to their pet and they don't even know. We've had quite a few patients like that, which is pretty interesting. I would kind of hone in a little bit more on that past family history. When he says father with some type of lung disease, I would say, that's pretty interesting. Brother with asthma, it looks like he comes from a family of lung diseases. So that's kind of in the back of my mind. Um, and that's pretty much, that's a good start, I would say. So then now that I know that this patient has asthma, a couple other things I would ask are medications. How is the patient controlled with his asthma? Do they take any inhalers like albuterol, any maintenance inhalers? Have they had any exacerbations? That's a big question with the asthma. Being 28, there's two different types. There's like a bivariate distribution of when you are diagnosed with asthma. It's either childhood, and if it's not childhood, then it would be later on in life, like in your 20s or your 30s. And the reason that you would get diagnosed would be a different subset or type of asthma, which we'll get into in a little bit. So this guy says that he was diagnosed as a child, and in his childhood, he had mild asthma and was just treated with albuterol. So to further delineate and see if this really is asthma, which I do believe it is when they're children or like when they're diagnosed early on, I'll believe it. But you always need to get different tests to see does this patient really have asthma. One of the most common things we have been learning or we've been seeing is patients with COPD being misdiagnosed as asthma or asthma being misdiagnosed as COPD. And this has implications with treatment. So does anybody know how to test if somebody has asthma? What type of test would we have this patient do or look for? Maybe the patient already had it. I'll just give you a couple seconds before I let you guys know. Okay. Anything in the chat or no?
No, no one's put in the chat
Okay.
yet.
Okay, yeah, that's not a problem. So this is called a pulmonary function test or spirometry with lung volumes. So in pulmonary function tests, basically what this does is it tests how we breathe. It tests how we are breathing right now and if there are any problems with our inhalation or exhalation. We'll get back to his numbers in a minute, but we'll talk about the pulmonary function tests to begin with. So this here is pretty much a chart or like our a lung volume study. And this here in the middle is called tidal volume. That's what we're doing at this moment. You and I right now, we're breathing normally. This is called tidal volume breathing. So just take in normally a deep breath in, a deep breath out. So this is normal, tidal breathing. At any given time, that's more than likely what we're doing. Now, if I tell you you're taking in and out a deep breath normally, then I say, breathe in as much as you can. Inhale, inhale, inhale. That's going to be your inspiratory reserve volume. So if you're doing a pulmonary function test, you would be breathing in and out into a like a straw-like thing. And then I would say, breathe in as much as you can, as much as you can, as much as you can. And that specific amount of volume is known as your IRV, or your inspiratory reserve volume. So that's something that we do check to see, is that number lower than it should be? Is it higher than it should be? Usually it's not higher than it should be, but we check to see if it is lower than it should be. And we'll talk about a little bit about that why after we go through all the numbers. So yeah, so normally you're breathing in this, let's say you're breathing in the straw thing. So you're breathing as much as you can, as much as you can, as much as you can. That's your inspiratory reserve volume. And no lie, that's what respiratory therapists, they yell at the patient, like, breathe in, breathe in, breathe in, breathe in. They encourage them or coach them, which is what you technically need to do. So that's your inspiratory reserve volume. Now I say you're normally breathing, just normal tidal breathing. And we see the way that patterns of someone breathes through it's called the Plethysmograph. I think I have a picture. Yeah, so that's like what it is. That's like a Plethysmograph. You're in a glass container and then you're breathing in and out through that thing. Okay, so you're breathing in, you're breathing out, you're breathing in, you're breathing out. Breathe out, breathe out, breathe out, breathe out, breathe out as much as you can, as much as you can. And that's going to be your expiratory reserve volume. So you're breathing out, out, out. It's really weird to breathe out of something. It's kind of weird. But anyway, so that's your expiratory reserve volume. So your inspiratory reserve volume, then your expiratory reserve volume. And whatever is left in your lungs is your residual volume. So that's pretty much that's the basis of what a spirometry or pulmonary function test essentially does. It tests how much air or oxygen, air was going into your lungs and how much is going out of your lungs. And this is really important for certain diseases. And this can tell us the difference between an obstructive disease or a restrictive disease. So if you think about something like an obstructive disease, you would have problems exhaling because they have a problem, they're obstructed. So then you would see a problem with their ERV area, with their expiratory, because they have problems with they have obstruction essentially. We don't know exactly where, but we know in the lungs they have obstruction. And that's what this tells us. Let's say somebody the way we look at this is based off a tidal volume for a normal person. And we say usually 6 to 8 cc's per kg. And that's based off ideal body weight. So if somebody is ideal persons, we can use like a 5-foot person. So 5-foot person essentially should be around 320 to 340 cc's. So if that's their normal tidal volume, and then you tell them to breathe in, breathe in, breathe in, and then they inhale maybe, when you're checking on the monitor, maybe 100 to 200 or 200 cc's, and then that's normal. But then for them, they're only doing 50. You're like, okay, there's a problem having air come into their lungs. So then you would think they're restricted. And then same goes for expiratory. So you expect them to breathe out a certain number and they're breathing out, but they can't, they only breathe out a small amount. They're having problems exhaling. Then you're like, okay, you have obstruction because you're having problems blowing out. So that's kind of the breakdown of chronic obstructive pulmonary disorder, or COPD. That happens in smokers a lot. 20% of smokers do end up with COPD. Things like emphysema and bronchitis sometimes, and that has to do with the airways kind of closing on themselves. Other types are problems with inspiratory reserve volumes or restrictive lung disease could be body habitus, like obesity, kind of like what one of you had said, how much do you weigh, or if they're obese. And this is because they can't just take in a deep breath. Also, if your lungs can't open properly, because if your lungs are like balloons. So if you think about it, it's something called compliance that helps the lungs open and stay open and then close properly. So they should be like a balloon. But if something happens where they become fibrosed, or something's around them that's not allowing them to open up as much, then you can see that as a problem. So COVID, that's pretty much what COVID affects. The lungs aren't able to open because they're filled with stuff, which so we'll talk about that a little bit, but because like something like COVID is known as ARDS, or acute respiratory distress syndrome. COVID causes that. And it just causes your lungs to fill with stuff and they can't open as much. So that's all these other things here that you see. The inspiratory capacity is just your inspiratory reserve volume plus your tidal volume. Like I said, tidal volume is the most important. It's the most important in the sense of that's what we're doing now. We're breathing in, we're breathing out. We're breathing in, we're breathing out. So if you take in everything that you're able to breathe normally, then you add in how much you can breathe out, your ERV, and then how much you could breathe in totally, that's known as your vital capacity. So your vital capacity is normal breathing plus how much, your max amount that you're able to inhale and your max amount that you're able to exhale. So that together is your vital capacity. And that's what you will see a lot on the pulmonary function test. That's one of the biggest markers that we look at. Your FVC, forced vital capacity. We call it FVC because it's forced vital capacity, because we're screaming at you to breathe normally, then we're screaming at you to breathe out, breathe out, breathe out, then we're screaming at you to breathe in, breathe in, breathe in. So forced vital capacity. And then here would be your residual volume. Okay, so if somebody has obstruction, would you think that the residual volume would be high or low? And your residual volume is everything that's left in your lungs after you maximally exhale.
So Miriam put in the chat that she expected it to be high.
Exactly. Great. That's the answer. You expect it to be high. And the reason you expect it to be high is because you have an obstruction. So these little key hints here will help you read PFTs. You'll be like a master already. So it's good to know this stuff. So yeah, so we talked about your FVC, your forced vital capacity.
She also had a question. She asked, why would obstruction not affect the RV? And wouldn't something obstructing expiration also affect inspiration?
Not necessarily. You use to inhale, you have to go through your, it's a different kind of system. So you go through your, when you inhale, you go through your nose, you go through your mouth, then you go through your piriformis sinus, then you go through your trachea, and then that's just kind of bringing air in. Now, if you had a obstruction at a central location, like a mass pushing on your major airways, then yes. But if it's a expiratory problem all the way down to your alveoli, then no. Because if you think about your lungs, they're like trees. So if your lungs are like trees, then you have branches, and then you have smaller branches, and then you have your alveoli that are like leaves. So it depends where the obstruction is that can cause both. But if it's all the way out in the periphery into your leaves, that happens in a lot of the COPD patients, then no, it won't cause a problem all the way through your bigger airways or the branches, because the branches will be open, but the leaves won't be. And essentially for gas exchange and for oxygenation, you need your whole tree working to make, if that makes sense. So you have bigger airways and smaller airways and the smallest airways. But you are right in that if somebody had a mass on their trachea, or a mass in the central airways or the bigger airways. So this main stem area here, this by our neck or inside our neck, is called the trachea, that comes all the way down and breaks off. If there was a mass there, then yeah, that would affect it. And we would see that on the pulmonary function test that we do. So that's another good way to kind of delineate, is this just the restrictive problem and obstructive problem, or both? And that can kind of give you a clue as to, oh, there must be something going on centrally, which is more worrisome. Okay, so this is an example of this patient, the asthmatic that we were talking about. So here's spirometry. Spirometry is just when you do what I showed you here. So the volumes are just spirometry. And then this is called lung volumes here. So to do lung volumes, it's a little more than just this, because this is your the lung volumes also include your total lung capacity, your slow vital capacity, your inspiratory capacity. This is a little more advanced, but for things that you guys should know, the spirometry part is all of this, and then the lung volumes is just one step above. So it helps you to see restrictive lung diseases pretty much. In addition to this, you can use this part with this, and then you can diagnose somebody with a restrictive lung disease. And you can also look at the residual volume here. But sometimes some places won't do lung volumes, they'll just do the spiral part. Because the spiral part, you can essentially do at bedside. So here, this guy has, if you look here, now that we know the numbers, we'll actually come back to this, let's talk normals. So we said that this is a Plethysmograph, and this is a guy who is blowing in and out into like a straw-like device, and then this is calculating how he's doing it. Now, if you see here, what's interesting is they close your nose. And the reason they do this is they don't want a confounding factor of air entering your nose or not. So this is straight from your mouth. That's why they close your nose while you do this test. So let's talk about normal numbers. So your forced expiratory volume over your forced vital capacity, we say between 70%, we say 70% is our cutoff. It depends on what criteria you're using. There's gold criteria, then there's American Thoracic Society. But for you, knowing 70% is a good number to know. So if you're below 70, if you're below, oh, sorry. So I guess this one's a gold one. So 80. So if you're between 80 to 70, then you're mild. If you're below, if you're between 50 to 70, then you're moderate. And then if you're 30 to 50, then you're severe. And then if you're below 30, then you're very severe. And this is to diagnose COPD. And what it means when it says below these numbers is the degree of obstruction. So if you remember, we talked about the forced vital capacity, and we also talked about the forced expiratory volume in 1 second. So that's essentially what FEV1 stands for, the forced expiratory volume in 1 second. And then the way we get this percentage is we divide the forced expiratory volume 1 second divided by the forced vital capacity. And that becomes a percentage. And we use this percentage mark to see how much obstruction there is. And this helps classify the gold stages of COPD. And the reason that it's important to classify the gold stages is to see if the patient will qualify for some type of treatment, and to see what type of treatment it would be. Would it be one inhaler or two inhalers? And would it be a muscarinic antagonist inhaler or a beta agonist inhaler or inhaled corticosteroid, or even further going to some other surgical types of procedures for these patients? So yeah, we said the FVC here. So just kind of putting it all back together, we have your IRV, your ERV, and then your vital capacity. So it's your forced expiratory volume in 1 second. That's not on here because essentially we can just do a forced expiratory volume in 1 second right now. How much are you blowing out in 1 second? So for a normal person, that should be 80% of your tidal volume. You should blow out 80% in 1 second. That's a normal person. Now, if you have obstruction, that's when it goes lower because once again, you have a problem exhaling. So that would go lower. And that's what we see with the degree of obstruction that we were talking about in that chart. So these are what we call flow volume loops. And this is kind of like what we look at to make a diagnosis sometimes. It changes your lung capacity, and your lung function changes as you get older. So here is normal to 20%, 20 years old, sorry, and the normal age 50 years old. You can see that here it's more rounded, and then here it kind of declines more at a slope. What happens is over every decade or so, you lose about 1% of your lung function a year, which is normal. So here is normal. So we'll start here because that guy, or our patient that we had, was normal, and he was around 28 years old. Here is normal. You can see here all the normals are outlined. And when you look at a flow volume loop, you look at here is flow, and then here's your volume. So flow is on the Y, and then X is volume. You see an obstructive, they're having a problem exhaling. So if they did not have a problem with exhalation, then it would be completely normal. They would be able to exhale high amounts of volume, high amounts of flow and volumes, given just at 1 second. So this is in seconds when they're blowing out. And so here, this person should be normal up here, but they're having obstruction, so they're having problem exhaling. So you can see kind of it going more low. And here, this is severe obstructive, so they're having even harder time exhaling. This should be normal, and then this is how much they're only able to exhale, which is really bad, like really bad COPD. And like somebody had mentioned or asked a question, if somebody has a problem or an obstruction, should they also have restriction as well? And that's kind of what you see here. So this patient here does have a problem obstruction as well as restriction, because this should be a little lower than it is, and here too. So this is called variable extrathoracic stenosis and variable intrathoracic stenosis. Basically, what this pattern here is telling us, both of these patterns, is that they're having obstruction at a major airway. So this is the extrathoracic. They could have a thyroid adenoma or something compressing their major airway. And that would once again cause problems with restriction and obstruction, kind of type picture. So here's restriction. This one we were talking about if you have problems just kind of taking in a deep breath because your lungs can't open properly, there's something kind of restricting the lungs from opening. That could be pulmonary fibrosis. The lungs, like we said, should be like balloons. They should be able to easily open, easily close. But if you have fibrosis, that's end stage lung disease. The lungs don't participate in gas exchange. They're kind of filled with stuff, but because it's fibrosed, it's irreversible. And so they're not able to take in as much volume or produce as much flow. It's more volume for them though. So that's why on the volume side, it's diminished. Okay, so this is kind of like flow volume loops. If you can recognize the severe obstructive is the major one to recognize for sure. And the sloping between a normal and then the obstruction. And another thing that's interesting to see here is a normal person can inhale and exhale very quickly. Inhale and then exhale. So the bottom part is the inhalation and this is the exhalation, the top part. Sorry, I forgot to mention that to begin with. So this whole top here is the exhalation and this is the inhalation. It's a little weird because you always think inhalation on top because it makes sense, but that's not how flow volume loops are. So it's actually the inhalations on the bottom and then the exhalations on top. So now I was telling you that this here is diminished, meaning they're having difficulty exhaling because this loop here on top is your exhalation. And then your bottom loop is your inhalation. So it kind of makes more sense that way too.
We have a question from Madison.
Yeah.
Sorry, I didn't mean to interrupt, but she asked, with someone who smokes or vapes, would their lungs look similar to the asthma?
No. So asthma, very severe asthma, yes, but somebody who smokes or vapes would have COPD. Somebody who has asthma would have a reversible obstruction. So the difference between asthma and COPD is it reversible or is it fixed? Fixed meaning it's irreversible. So COPD, it's irreversible to an extent. You always have to be on bronchodilators, but asthma, it can be reversible. And that's the major difference actually. They both are obstructive processes, but one is reversible and one's not. So the pathology, the pathophys behind them are somewhat different. And actually we do get into that in like a couple slides. So this is kind of explaining a little bit about what we spoke about. Here's your, like we said on the top, this is your expiration. So here's showing your expiration and this is showing your inspiration. So always on the top, anytime you see something on a flow volume loop, the top part's always your expiration and your bottom part's your inspiration. You have flow on the Y and then volume on the X. So you can see how it's coved here because they're having problems with expiration. And then here it's even worse and more significantly coved because they're having even severe obstruction, even worse. And then like we said, you can have problems with both. And all three of these are showing us that you can have problems with inspiration and expiration. So this is kind of a little bit what we spoke about, the GOLD criteria for COPD. And we spoke about in your forced expiratory volume in 1 second, you should breathe out about 80% of your lung capacity. And then if you're not, then you have obstruction. So below 70 would be mild, and then 50 to 70 here would be moderate, 30 to 50 severe, and then below 30 would be very severe. Below 30 is when we call them end stage COPD, and that's when we start talking about kind of palliative end of life care for these patients because they're on oxygen at this point. If they're very severe, they are on oxygen, nasal cannula at all times. So even if they go to the grocery store, if they're walking around, if they're sleeping, they're on oxygen. And it's just because they can't keep up with, their lungs are so damaged that they can't oxygenate. Their lungs just can't oxygen. And we'll talk about a little bit about why. So this is kind of it's a little busy. It's a pattern that shows us obstruction and restrictive, different types of patterns based off the pulmonary function tests. So here we said 70%, 80 to 70% is, so you should have at least 80% blowing out in 1 second. So if you're normal, then you can kind of follow this in normal, and this kind of can lead you to a restrictive pattern or a normal pattern. And then if you're below 70%, that's when you start your COPD, your obstructive diseases, and that can lead you to obstructive pattern. And there's a couple other things that you do look at to see if this is a mixed pattern, or there are certain things that you can look at to see if this is going to be a restrictive pattern. Okay. So before we go into the DLCO, we're going to talk a little about asthma, because you had mentioned about asthma. So asthma is a long-term inflammatory disease of the airways of the lungs. It's characterized by variable and recurring symptoms, reversible airflow obstruction, easily triggered bronchospasms. So yeah, the difference between asthma and COPD, this is reversible. And the reason it's reversible is because of different types of cytokines that are involved in asthma. So it's interleukins and cytokines that are involved in asthma that cause it to be that can cause it to be reversible depending on a trigger. So let's say somebody's exposed to something that causes their IgE level to be really high, which is immunoglobulin E, or their interleukin 5 or interleukin 6, or even histamine, bradykinin. All of these mediators can go to the lungs and cause the lungs to close. And when I say close, not close at the central level or even a big airway level, more towards the branches, if you call it, the smaller branches, and that closes right before the leaves. So if that area closes, they don't participate in gas exchange or in oxygenation. So oxygen it's hard for them to breathe, and it's hard for them to exhale. And it can be due to environmental factors, genetics, triggers, and environment. What we've been seeing in asthma is very familial. So, or it's likely familial. If in this patient, his brother had asthma. So that was pretty interesting to kind of put it up there. Environmental factors, sometimes seasons, people get very triggered by the cold, and then some people get triggered by the heat. The way we classify asthma, so for that patient, if he was to come into the office, and through when you guys do study asthma, you'll see it's classified as intermittent mild, chronic persistent mild, chronic persistent moderate, or chronic persistent severe. And this is based off daytime symptoms or nighttime symptoms. And so depending on how many times a month or a week, that's how we would classify them. And that can help with our different treatment. And here you see a peak flow while exhaling. So 80% is how much a normal person will exhale in 1 second. We have a peak flow that we give each asthmatic, and it tells you on there, you blow out in 1 second. You just go, that's what you do. You blow out, and then you see how much volume you exhale in the second. If it's 80%, it will be in the green. If it's like around 60%, then it drops down to yellow. And then if it's in the 50 or like below, it goes to red. So green, yellow, red. And this tells an asthmatic that I'm starting to get obstructed. I either need to call my doctor and get a steroid pack to decrease the inflammation so I can exhale more, or I need to go to the hospital. And that's kind of what we do use for these patients when they are home. It's called a peak flow. And so this is kind of how we treat these patients. We start off with intermittent. We do a short acting beta agonist, which is albuterol. So we'll start with albuterol as needed, PRN, and then we'll add in inhaled corticosteroid. So that's another type of inhaler. And then we'll kind of just keep going up. We'll keep stepping up therapy until they're more controlled. And then at the end, if they're still not controlled with the triple therapy inhalers that they're on, then we will add an immunologic. And so these are the immunologics. We kind of spoke about asthma being mediated by different types of interleukins, histamine, bradykinin, interleukin 5, interleukin 4, interleukin 13, and all of the immunoglobulins, specifically IgE. All these, what they do is they just crowd the airways, and then because they crowd the airways, they cause the airways to close. If the airways are closed, you're not breathing essentially. So that's what what we do with these medications, we target the specific thing that's causing the airways to close on themselves. The way we are able to see if the patient even qualifies for them, we order an IgE level on these patients. So we'll do some blood work, we'll get an IgE level, we'll check their eosinophils, and we will also check a RAS panel is what we call it, which is an allergy panel, essentially. That we'll see, it's like a panel of like 20 different things to see if they're allergic to like ragweed, pollen, hay, dogs, cat dander, different types of things. So we do that in the clinic when somebody who has asthma comes in. And once we know that information, we can say avoid dogs, avoid cats. We had a couple patients that have actually come in and they've had dogs or cats, and then we tell them they're always like very, very short of breath, and they're like, what's going on? And then we do this on them and we find out that they're actually allergic to dogs or the cat or the pet that they have. And then we tell them this and they're like, well, I got to live with it. So at that point, then we'll desensitize them, or we will expose them to small particles of, if it's, let's say it's a dog, let's say that the 28-year-old was allergic to his dog and he doesn't want to give up his dog. So we desensitize him. We'll give him little dog dander or just pieces of dog kind of allergen, and we'll inject him into it, small amounts in a controlled setting until he's not allergic anymore. So that's what we sometimes do for medications. If a patient needs a certain type of medication like penicillin and they're allergic to penicillin and they can only get penicillin, then we would do the same thing. In a controlled setting, we'll keep giving them small amounts. There's always epi nearby, and then there's steroids nearby, Benadryl and aspirin. So we essentially just kind of treat them. So there have been all these new medications I'm talking about right now, all these injectables, they're called monoclonal antibodies. They are on the newer side. So before these monoclonals, all we had was albuterol and just inhalers. So it's good now that we have all these new medications, because asthma it's a big deal out there. There's a lot of asthmatics. Okay, so this is an example of a spirometry, or the breathing test that we were talking about before. So just looking at these, we have our forced vital capacity. So this patient is at 50%. The forced vital capacity. And then, so I'm already thinking in my head, this is low. 50% is low. 80 should be normal. So this patient is at 50. I'm like, okay. So then I go to the forced expiratory volume in 1 second. That's 17. That's like so low. That's extremely low. So that he's like barely inhaling and exhaling. Then I'll look at the percent here, the FEV1 over FVC, and his is 33. 33 when he should be at anywhere from 70 to 80, and he's at 33. That's like, where's his lungs? So sad. But yeah, so this, I would say, severe obstructive disease. This is somebody who has severe obstructive COPD. And this is the patient's CT. This is what we call emphysema. Emphysema is a type of COPD. There's a bronchitic type, and then there's an emphysematous type. If for some of you who are now reading for school, if you've heard like pink puffer or blue bloater, this one would be the pink puffer. And you can see here all these big, they're called blebs. They're areas of lung that just get damaged, whether it's nicotine that just goes into all the airways, into the smaller airways. So when I was telling you guys, the lungs are like trees, you can see here are the branches, and it kind of branches out into smaller airways. And all these little circles here are kind of like the alveoli or the leaves. And they kind of get damaged if someone has COPD. So this patient has COPD, been smoking for years, and you can see that this whole area of his lung is not participating in oxygenation, and it's not participating in gas exchange or ventilation. And what this means for this patient is he lives off maybe he probably has like 1.5 lung, like 0.5 of his lung is completely destroyed. And the lungs are not the liver, so they do not regenerate. In this patient, we would just prevent him from getting worse.
We have a question from Julian. They asked, what does the lung volume test get that the spirometry test doesn't?
Yeah, that's a great question. Okay, so before we get into that question, so lung volumes, it will So spirometry can tell us information. Lung volumes solidify it, if that makes sense. So it's just more information. Let's go back to this patient actually, because he had a good one. So this is the spirometry part, and then this is the lung volumes. The lung volumes will tell you more. So if I'm suspecting somebody has obstructive disease, I would like to see their residual volume to be like, okay, this residual volume is like 200. Then yeah, this patient's really obstructed because he has so much air just in his lungs that he can't blow out. This patient's fine though. This patient's residual volume is fine. Now, let's talk a little bit about this patient's pre-bronch and post-bronchodilator, because the spiro part is important to diagnose asthma versus COPD. So the first thing that we always look at is we look at this ratio, FEV1 to FVC. And you always look at percent predicted. There's a lot of numbers on here, but for your guys' level, you guys should look at the percent predicted. So this patient's at 73. So I'm thinking, okay, could be slightly obstructed, maybe not. It's not below 70, so probably not. It could be normal. So then I look at the FVC and FEV1, a 28-year-old healthy, this is good. 165%, 121%, that looks good to me. And what it means by pre-bronch and post-bronch is bronchodilator. So they get albuterol. These patients get albuterol for the post-bronchodilator part. And the reason they get the albuterol is to see if the numbers change. So let's say this patient isn't asthmatic. So look at the numbers before. 165, 121, 73. And other numbers that you do look at is here, the decimal points. So for the FVC is 2.23, FEV1 is 1.72. These are the only two that you really care about for the predicted. So in this patient, he got albuterol. Then it went to 3.64 and 2.53. So you can see that. And then you also look at the percent like we talked about. So it went from 165 to 163, 121 to 147, 1.72 to 2.53. So the FEV1, forced expiratory volume in 1 second, was only 121%, 1.72. Then you give this patient albuterol and it goes to 2.53. That's a positive change. They're able to exhale more. If that kind of like makes sense. So it means that the airways are closed. They're only able to exhale 1.72. You give him albuterol and now he's at 2.53. That's greater than 200 cc change. That's what we look at. 0.200 cc's change in your FEV1 or your FVC. So you need the 200 cc change between your predicted pre-bronch and your actual post-bronch, and you need 12% here. So this patient meets the criteria for asthma because he had the 200 cc change plus the 12% in bronchodilator response. So pre-bronch, post-bronch, you can see that this patient has asthma. Okay, so just to kind of say it again, if enforced expiratory volume in 1 second, it should be 80% of someone's lung volume. So this patient here has 1.72 or 121%. This is pre-bronch, or 2.23 and 165% pre-bronch. Then you give this patient albuterol and he comes out at 2.53 and 147% with a 21% change. So in that already, I know it's asthma. He has a positive bronchodilator response. And it's like a guideline criteria. You need 200 cc's and 12% change. Okay, so that's how I know that this patient has asthma. There's a couple things that I skipped that for the sake of time because there's one other case that I wanted to get to. All right, so we have a 32-year-old female with history of diabetes, hypertension, comes to the ER for shortness of breath. Very tachypnic on exam, diaphoretic. Tachypnic means she's breathing very quickly, and diaphoretic means she's sweaty. Diabetes, DM is diabetes mellitus, and hypertension is, or HTN is hypertension. And she comes in for shortness of breath as well. She can't speak too much. We can't elicit too much from patients, or her husband is in the room. And he says they were at a party last week. So vital signs, heart rate's 125. So the patient is tacking away. Her heart rate's very fast. Her blood pressure is 180 over 110, which is elevated because we know 120 over 80 is normal. and she's breathing only 78% on room air. We expect a normal person to be 98% on room air, not 78. 78 is extremely low. And she's breathing, RR is respiratory rate. She's breathing 38 times. A normal person, us, we breathe 10 to 12 times a minute. If you actually sit there and count how many times we breathe, it's normally 10 to 12. She's at 38. So you know there's something wrong with her. So first thing we do when this patient comes is we get a chest, or for the sake of time, I'll just keep talking. For the first thing we want to do for this patient is we get a chest x-ray. This is her chest x-ray. And for anybody, for all of you guys, this is bad, really bad. So to know bad, you have to know normal. This is normal. You can see here, everything looks clear. There's a lot of black, and black is good. Black means air. On any imaging, black means air, whether it's head CT or CT thorax or chest x-ray. So yeah, so this patient is normal. This patient is not normal. So this is what that patient came in with. You can see here there's not much aeration going on. There's not much ventilation going on. All right. So this is bad. She came in, she got a chest x-ray. It's horrible. Then we did some blood work on this patient because we're already thinking COVID in our minds. So a couple things that we do get for patients with COVID is we get a ferritin, we get D-dimer, and we get a CPK level. You can see that all these are extremely elevated in this patient. These are all inflammatory markers that we look at in patients with COVID to see if they're high to give us the diagnosis of COVID. So let's talk a little bit about COVID, what it is, and why it's so important to wear masks. So COVID, I don't know how to make this. Got it. Okay. So COVID can reach people through the eyes, the nose, or the mouth. And this is why they say you should double mask, or you should double mask. And when you wear the mask, you need to cover your nose and your mouth. And you should also wear a face shield or goggles to be even more proper, because it can enter through the eyes. You should stand 6 feet from each other. You can get the virus through any type of respiratory particles, whether it be talking, sneezing, coughing, laughing, anything. So this is how the virus is. So this is SARS-CoV-2 virus is what we call it. It's an RNA virus. Around the virus, there's these things here, and those are known as spike proteins. These spike proteins attach to, let's pretend this is a cell. The spike protein attaches to our cell through the ACE receptor. So spike protein here, it's attaching to the ACE receptor. Once it attaches to the ACE receptor, it enters into our cell. Once the virus enters into our cell, it releases its RNA. And I know a lot of you guys or some of you guys are studying for your MCAT and have taken some medical training, so you know what RNA and DNA is. So what RNA does is it continues to replicate. So it's ribonucleic acid. It enters the host cell and it uses the host cell to create new RNA particles, or new RNA virus particles. This is the cell. Because the virus had released its particles, it uses the host ribosome. So it uses, if we were to get it in our body, God forbid, then it will use our ribosomes, and through translation, polyproteins, it will make its own replication and make its own virus particles. And then once the virus particle is made, it is then released into our body. So when it comes into our bodies, the lungs is one of the places that it loves to go to. Just backtracking a little bit, when I said like the lungs are like trees, this is how I describe it to all of my patients. So this is your trachea, and it breaks into your right and your left main stem bronchi. You see here these branches or bronchioles, they're airways, and then it goes into smaller airways. That's a side note. So anyways, the virus particle, this virus particle, likes to go into our lungs because here is full of ACE2 receptors. So all through our lungs have ACE2 receptors. And we said the virus needs the ACE2 receptor to bind the spike protein. So it gets into our lungs, and then our lungs are lined with what we call type 1 and type 2 alveolar cells. Type 2 alveolar cells is important because it produces surfactant. And we need surfactant to keep our lungs lined with some type of fluid so they can be the balloons that we were talking about. If the lungs don't have this balloon, then it won't. If the lungs don't have this surfactant or this thin layer of fluid, it cannot move easily as it should to inhale and exhale. So these two cells are important. Now, what COVID does is it comes into our cells, all those virus particles, like we spoke about, went through RNA, used our host cell to replicate itself, and then came into our cells through the ACE2. It goes into our lungs, and then it destroys our type 2 alveolar cells. So if it destroys our type 2 alveolar cells, then they can't, it causes destruction. And then once the virus particle is in, that activates our macrophages in our body. Our macrophages will then come and try to kick or kill the virus particles. So when our macrophages come and try to kill these virus particles, it releases a cytokine storm. And that's what causes all the major effects of COVID and why patients get so sick. Some patients get a worse cytokine storm. Some patients don't get as bad as the cytokine storm. But by destructing our type 2 alveolar cells, that fluid is lost. And then when those fluid is lost, then you see here, it loses its that fluid here. And when that happens, when it gets lost, the lungs don't expand, and it allows for stuff to come into the lungs and into the alveoli, or the leaves, like we are calling it. This is healthy, this is infected, this is bad, and this is really bad. You see things just get stuck in the alveoli or the leaves. And when things get stuck in, they don't move. And when they don't move, they cause impaired gas exchange or low oxygen saturations. Okay, so just a little bit more about COVID. So these are certain types of labs that we order, like we spoke about. A lot of these have to do with the cytokine storm. So your ferritin, your LDH, CPK, your lymphocyte count, that's kind of your it's like your white count, but this is specifically what we look at are one of the specific markers for COVID. Procalcitonin, your coag panels, troponins, all these are just lab tests. So COVID affects almost every organ in the body. It affects everything, actually, from your head to your toes. So neuro-wise, it can cause headaches, dizziness, all these symptoms. It can affect the kidneys by causing kidney injury. A lot of these patients do end up on dialysis. It can cause liver failure. It can cause diarrhea, nausea, vomiting, abdominal pain. It can even give, interestingly enough, rashes, which one of the newer things that we did learn about. It can cause endocrine problems like hyperglycemia, which is a problem in diabetics. It can cause heart problems. And the reason that it can cause heart problems is because the heart also has ACE2 receptors. And we said that the virus needs ACE2 receptors to bind. So the heart has them as well as the lungs. And it can cause blood clots, thromboembolic diseases. We've been dealing with a lot of COVID here. Well, I have been dealing with a lot of COVID. And since it's so relevant these days, I figured I would throw out a case out there for you guys. So that's all I had. I hope all of you guys learned something / enjoyed. That's actually not my Instagram. My Instagram is NeensMD. If you guys want to kind of follow along what I do on a daily basis, I do post a lot of stories on what I see and what I do. Like today we saw 2 chest tubes. So I talked about a little bit about that. I talk about just different cases, things, take you through my day and my stories. This is my email address. If you have any questions, reach out to me. I love this saying. I think it's super relevant. A journey of 1,000 miles begins with a single step. I believe that this is so relevant because it's so hard to start, but once you start, you should keep going. I think I see some questions. We can take it from there. Any questions you guys have?
A lot of people are saying thank you, and that they thought it was really interesting. I thought it was also cool that you presented a COVID case, because I've never seen like an X-ray of a COVID patient.
Yeah, it's bad. It affects like everything in the body. And now you guys are a lot smarter, and you can tell everybody what COVID really does and encourage all those masks and vaccines.
Yeah, I get my second dose Monday. Yeah.
Oh, good.
Yeah, so I'm excited. If anyone has a question, you can unmute yourself or post in the chat. I don't know if you feel comfortable talking about not just like the cases, but like your journey through medical school or.
Oh yeah, absolutely. Yeah, definitely. I ended up going to Caribbean med school, and I get that question a lot, like, why did you choose AUA? Why did you go to a Caribbean med school? And if I had to do it again, I would 100% do it again. So when I was an undergrad, I think I stretched myself a little too thin. I was in like 6 different clubs. I was doing a thesis for research. I was president of my sorority. Always live your best life. I'm a huge believer in that. So I definitely lived my best life. In addition to being in a lot of clubs, you put like a lot of pressure on yourself to like, oh my God, I have to get into med school. I need to do everything I can to get into med school. And because people put a lot of that pressure, it takes a lot of stress. And when it takes stress, you're reading, you're hearing it, you're seeing it, but you're not really comprehending it. So that kind of puts a fog on your mind, like a mental block kind of. So I wasn't the most efficient studier / schedule prioritizer, which is something that I've gotten a lot better at, thank God. But I wasn't at that time. It took me a while to learn. I had a decent GPA, and I took the MCAT. I was not content with my score, and I didn't want to take it again. My cousin had gone to the Caribbean med school, and then she was actually practicing or in her residency. And then my mom was like, or my parents, they were like, well, if you're not going to take the MCAT again, then you should consider Caribbean school. They thought they were threatening me by saying that, but they weren't threatening me. I was like, okay. So I didn't have to take the MCAT again. I kept up a good GPA. I used whatever MCAT score that I had. And I applied to the Caribbean school, and I had a blast. I really think that the Caribbean school has some type of stigma associated with it. I don't really believe in the stigma associated with it to an extent. I'm just going to go to the last page just so you guys can get my info. I do think that there is a stigma that is attached because people don't really know too much about it or aren't familiar with it. Where I think the stigma is not reasonable, but where I think the stigma should be put emphasis on is how is the amount of things there is to do. I forgot what the word is for it now, but you're on an island. You have every distraction in the world, and you can do anything you want. And that's where the fallout happens, I would say. Because I started out with maybe 230 people in my class, only half of us made it. And that's almost every med school class that I've heard of from the Caribbean. You have a lot of distractions. You can do anything you want. So it's all about balance. It's all about prioritizing. It's all about scheduling, and it's all about studying and kind of putting your mind to it, I would say. I see somebody said, I'm in a sorority, but I am nervous it would look bad on a resume. Do you think there are a lot of employers who believe the stereotype, or would holding a position be beneficial? So I was in a sorority. I was president chapter. I loved it. And I think honestly, it adds more than it does deflect, especially in this day and age. Everybody's all about living their best lives. Everyone's all about equality. Everyone's all about just being the best you, but being smart about it. So if sororities are, I think they're great, and they add leadership qualities, leadership skills. It really depends on how you look at it. They're not an easy thing, but if you're able to prioritize that, then I don't see it as being stereotypical in a bad way at all. I think you should twist it to your benefit. Just a question about the USMLE step 1 and 2 CS becoming pass fail. How do you think that will affect IMG's applying to residency? That's a great question. It's interesting nowadays to be a med student out there because of all like the physical exams being kind of stepped down because of COVID, and step 2 CS just being canceled, and step 1 being pass fail. I think it's going to have a implication on IMGs. I can't really answer at this time exactly how. I think there's going to be a lot of emphasis on step 2 CK. And I think for IMGs, maybe taking your step 3 and doing well on it will show more of an effort per se, because that kind of makes you that'll make you more competitive. The fact that you took your step 3 and did well. Step 2 CK there'll be a lot of emphasis placed on that score, I think, as well. Kind of learning for IMGs, it will be a little difficult to learn the CS skills. I know I was forced to learn the CS skills because of I had to take step 2 CS, and I came from the Caribbean med school, so that is a little different. That's a little different coming from the Caribbean med school because we don't get the same. We do to an extent. I would say that we practice on like patients in the Caribbean, so it's different than what they do here. Because I get Wayne State med students sometimes that do rotate with me on in the outpatient setting or in the hospital if I'm in the ICU or something. And so like I see what they do and what they go through. There are differences for sure, but I think once again it's all how you make it and how you study and how you approach the situation. What was your undergraduate degree and what inspired you to study medicine? My undergrad degree, I was boring. I was biology and psych minor, the normal. What inspired me to study medicine? My mom. I always knew I wanted to do medicine. So my mom's a family physician, and so ever since I was young, I would always see like patients coming up to her, and they would just talk so highly of her, and she was so well respected in like the community, and just how much I would always hear she's changed people's lives, this and that. I didn't really understand it until I was like more in high school. And in high school I volunteered at a hospital. I was able to get hours. I was like the person who checked people into the hospital or something like that. I forgot, it was so long ago. But I always thought it was really cool that just to see the amount of respect and how much she's changed people's lives. They had such a connection with her, all her patients, because she's family medicine. So she is outpatient. And I just think that it's great. And that I was like, okay, I know I want to do medicine, but I don't know what I want to do in medicine. She was definitely my big inspiration. I think I kind of figured out when I wanted to do pulmonary when I was in residency. And I figured out I wanted to do critical care when I was in med school. In my 4th year med school, I was able to do an ICU rotation. And I still remember it. There was a code on the floor. This patient was like completely pulseless. It was like code blue, and patient was dead in my eyes. I was like, oh my God, this is code blue. The patient's dead. And so the ICU doctor came running down, and then the person was just screaming orders like, what time did it start? What was the rhythm? Did you give epi? Get ready, compressions. And I just thought it was so cool. I was like, I want to be that. So I always had inspiration from that. It was kind of more of an experience that I had that I was like, that's what I want to do. Any other questions that you guys have? If you guys don't think of anything right now, you can always feel free to email me. My Instagram is actually NeensMD. And that's the website that I kind of have that has to do with fellowship and kind of like my personal life.
Yeah, well, I can give the closing statement, but I don't know how much time you have after we finish the recording, if you'd be able to stay on after if people have questions.
I'm actually I have dinner, but please do feel free to email me.
No, that's perfectly fine. But thank you so much for this incredible and insightful session, Dr. C. I really enjoyed how interactive and encouraging you were, and I hope to have a session with you again in the future. So I know you put your contact information on the slide, but if you wanted to put it in the Zoom chat, you're more than welcome to. And also to our Wayne State University students, please make sure to complete the Google survey posted in the Zoom chat summarizing this session to obtain your shadow hours. So thank you, everyone, and I hope you have a great night.